Good afternoon, everyone. My name is Isabella Dinelli. Today, I'm going to be presenting a case of neurosarcoidosis with a very unusual presentation. I'm from the University of South Alabama. I'm a med student there, and this is a case from the internal medicine department. So some of our objectives for today are to review the typical features of sarcoidosis and how this is an atypical presentation. We are going to highlight how cardiac conduction issues can serve as a sentinel sign in cases of sarcoidosis. And then we're also going to discuss the different diagnostic and treatment challenges involved in management of sarcoidosis, particularly when the optic chiasm is involved. So first, what is sarcoidosis? Sarcoidosis is a multisystem granulomatous disease of unclear etiology. It is non-caseating in affected organs. It most commonly involves the lungs. Hyaluradenopathy is the most pathognomonic thing they kind of teach us in med school. It can also present in the skin, erythema nodosum, and then the eyes and uveitis. That's kind of our classic triad that we're taught. But less commonly, in less than 5% of cases, it'll affect the heart. And then it can also present in the nervous system, anywhere along the nervous system, really. Both of those are very rare, and then having them occur concurrently is also very rare. The typical symptoms are going to include cough, dyspnea, fatigue, very generalized systemic. Lab workup, it can show an elevated ACE level, though this is neither sensitive nor necessarily specific for it. So it doesn't necessarily rule it out when it's normal. And so with our patient, a lot of this applies. She is a 45-year-old woman. When she presented to us in the ED, she was describing about a month of progressive bilateral blurry vision and then some color vision loss. She was also describing retroorbital pain, but it was not with extraocular movements. She had been prescribed previously a steroid taper outpatient that was not helpful at all. She had a very interesting history. There were findings of neuraxial tumors that were incidental. It was following an assault she sustained at work. She had never really had any symptoms of it, but over the past year, she slowly started to develop some radicular pain. She was also describing some bradyarrhythmia. That outpatient was followed. Again, not suspecting sarcoidosis at this point. They put a Holter monitor on her, and they actually found her in complete third-degree heart block. And so, of course, she had a pacemaker put in, and then the rest of this kind of neurosarcoidosis presentation started, where mostly with the vision loss. And so our diagnostic workup, when she came to us in the ED, she was hemodynamically stable. Her main findings were decreased visual acuity and color vision loss. Again, normal extraocular movement, no focal neurologic deficits that we could appreciate. With her workup, it wasn't very remarkable at first. She had a very normal CBC, unremarkable CMP. Her ACE level was unremarkable as well. We did some brain imaging, and then, of course, we found what we see in figure 1 as well as figure 2. So we saw some new lesions in the optic chiasm, likely explaining some of the neurologic symptoms, the vision loss that she was describing. And then you can see a lot of the neuraxial tumors still within figure 2. So we also did a lumbar puncture, and her CSF showed lymphocytic pleocytosis. So these findings together, combined with her clinical course, led to a diagnosis of neurosarcoidosis. And so at this point, our main concern was vision preserving treatment. So what we needed to do first, we did a high dose IV methylprednisolone for 5 days, and this was an immediate effect. Overnight, she described her vision improving 50%, and every day was really fun to follow her because it was so dramatic for her. And prior to this, when she was on the steroids, outpatient, it really didn't help, but it was really the high dose steroid that made the difference. She was transitioned to infliximab after we ruled out infectious etiologies such as tuberculosis because it is a TNF-alpha inhibitor. So we wanted to make sure that she didn't have anything that was going to disseminate when we're trying to treat her relapsing disease. She was later diagnosed on a prednisone taper with almost complete vision restoration. And then we had her scheduled for infusions outpatient. And one other thing that we had to rule out with infliximab was also the hepatitis. So those are our two main teaching points that I wanted to talk about today is, of course, when we are doing vision preserving therapy like this, we want to make sure that we don't make underlying disease worse. So hepatitis and tuberculosis are our two biggest things that before we start anyone on infliximab, we want to make sure we rule out that they do not have. I wanted to also talk about how this is atypical. So in med school, we're kind of taught about ACE levels being elevated all the time in sarcoidosis. We're taught about the lung findings. So when this case presented to me, I was not really suspecting sarcoidosis at all. And so that's why this is something I was so passionate about and learning about. Neurosarcoidosis is very rare, and especially this type of presentation where it's not really showing any of the classic triad was very interesting to me. And then just, it was very multidisciplinary. We had ophthalmology come in, neurosurgery come in, neurology come in. Of course, we had internal medicine managing everything, but it really took a team to kind of take care of her. And she literally improved dramatically overnight, which is something we don't typically see with these types of cases. So that was something that I found really interesting. And then just to make sure that with any disease pathology, really, any type of system you choose, sarcoid can always kind of be on your differential, just because it can literally affect any type of organ. So even where you think maybe the typical diagnostic clues are not necessarily present, if there's something that's systemic and isn't really explained by other things, I think it's so important to include sarcoidosis on your differential, especially if you're somewhere like South Alabama, where we do have a higher African American population, and this disease does tend to affect that population a bit more. So ultimately, this is just a very rare case of how a cardiac manifestation can lead to the discovery of the multisystem sarcoidosis. It's important to be prompt with your management so that we're able to preserve our patient's vision. And ultimately, we were able to. So thank you very much. If there are any questions, I can answer them now.
Here is a question. Have you seen any degeneration of your patient's quality of life, excuse me, or increased lesions since the start of treatment? No,
it has actually been pretty, it's been pretty dramatic. She hasn't had any relapses. She, I guess, previously did, given that she didn't really respond to the steroid taper that she was on outside. But I think the infliximab is specifically for when a patient fails steroid treatment. And so that helps prevent the reinitiation of the disease, the relapsing. So no, she's done very well. And actually, I've seen other cases of neurosarcoid that have presented in completely different ways, of course, in different parts of the spinal cord, actually, and they had the same sort of results. So
thank you so much.
Of course. Thank you for having me. Any other questions?
I don't have any in the chat.
Okay, perfect. Thank you. Y'all have a good rest of your day.
Thank you. You as well.
Please support our mission to improve quality of patient care through education. Join us, follow us, and share this content with family and friends.